I'm Jacob Martinez. I'm the Director of Business Development for Mountain Home Health. And I was on the tent board, I think, for like close to 3 years. I don't know. Somebody correct me if I'm wrong. And had a wonderful time doing that. And I think I encountered tent through my work with Mountain Home Healthcare and just thought what tent was doing was really forward-leaning. I worked in the DC metro area and then in rural North Carolina. And this type of, what tent was doing was talked about a lot, but nobody in those areas that I have run into. I'm sure there are things, and we know now that there's villages everywhere. But I didn't see it playing out, so I was really excited and still am for what tent can offer the Taos community insofar as keeping people in their homes and aging with dignity. So I'm a native Appalachian from North Carolina, and that's not what this presentation is about, but if you're interested, I will give you one. So the hillbilly may slip out sometimes. So I've been here for almost 4 years, 3.5 years, doing this, and I work here in Taos, but as you know, most folks that have some kind of acute need, mostly if it's ortho, they'll tend to stay here. However, if somebody has a cardiac and neurological event, something of that nature, they're going to go into Santa Fe or into Albuquerque, depending on acuity. And so when I use, does everybody know what the word acuity means? Mm-hmm. So acuity depends on at what stage of decline, and it usually refers not to the decline of the disease process, but in what resources that you need now. So when we talk about a hospital, we talk about an acute care setting. And that means that your situation is acute and you require that type of attention. So anybody that has a critical acute need often goes into Santa Fe or Albuquerque, primarily either to the PRESS system or to the Christus system. And that just depends on what it is and who's got a bed available. So I work out of Santa Fe and Albuquerque a great deal. And I've been doing this in some type of capacity for almost 8 years now, and I've been in healthcare for about 10. So I started in primary care. I then went and worked with lab diagnostics for about a year doing DNA testing. And then I started working with skilled nursing facilities and then got into home health and into hospice. So I feel like I have a broad perspective. Mountain Home Healthcare has been here since 1975. In a couple of years we'll celebrate 50 years. We started as home health. A few years later we added the hospice to Larry Shriver, so I'm sure many of you are aware of his legacy. Private duty care, and we'll get into that a little bit more, what that means. And we'll also talk about the difference between home health and home care, because those are two distinct things that often get used interchangeably. And last October of 2021, we launched a palliative care program, and that is to assist folks who have a terminal diagnosis and or several comorbidities that are exacerbating decline that will ultimately lead to death. So they have so much, they don't have a terminal diagnosis, but they've got so much going on. Maybe that's that they're diabetic and they're obese and they have a compromised respiratory system, and everything's playing on everything else that's leading to just a gradual decline. And that's something, hospice is only for if you're within 6 months. People last longer, but 2 physicians need to stay. We believe that this person will pass within 6 months. And in palliative care, we look at 18 months. So we're trying to catch people and support them prior to that 6-month mark. And under palliative care, in the way we practice it, you can still be seeking curative treatment. So that's the other thing. So if somebody had, say, for example, stage 4 breast cancer, they could still be seeking, they could be on palliative care, still be seeking chemotherapy and radiation, and also still doing all of those things and getting as many services. And we'll talk a little bit about the difference, if that allows. So just as a ground rule, if you have a question when it comes up, so what we're going to be talking about today, we're going to be moving through lots of different entities, facility types, regulations. So if you have a question that comes up, because we could do a year-long series every month and we still wouldn't cover everything that's in this. So we're kind of going over as much as we can. So today we're talking about traveling through the care continuum. And what I mean by the care continuum is all of this. So when we talk about the care continuum, it means everything from primary care. As you go to primary care, you may get a referral into home health, and then you're back to your baseline. So primary care, in theory, should keep you at your baseline functioning. Your average daily activities stay normal. And then as something changes, you begin traveling through the care continuum, and that can mean lots of different things. So that can mean monitoring, diagnostics. You guys know telehealth is a big thing. With diabetes and even cardiac stuff, we're getting more telehealth monitoring. So that is the part of traveling through the care continuum. What we're going to focus on today primarily, we're not going to focus on diagnostic testing. We're not going to focus on primary care. We're going to talk about what happens when I go to the hospital. I have a fall, I have a decline, I have an event, and then how do I move through all of that, and how do I navigate that? And I think I already said that. So the first setting that we're going to talk about is the hospital setting. So Jane Doe or John Doe, it's cold, there's ice. I don't know about you guys, I almost busted my butt today leaving on my patio because it's just ice. So I go out there and I'm coming to do this for you guys, and I fall and I break my hip, right? So I enter into the hospital setting. There are two types of hospital admissions, and these are crucial to understanding what services that you can access. So, and there's also, so you can go in through the ER, 911 emergency service, you can present in person to the ER through your family, and you may get some diagnostics done, and the physician, the attending says, oh, I think you've got to be admitted into the hospital. And then if you, of course, have an elective surgery, your orthopedic surgeon or somebody like that is also going to admit you, and you didn't come in through the ER. You're coming in through like same-day surgery or outpatient surgery, and you need to be admitted for whatever. Maybe there's a complication that arose. So there are two types of hospital admissions. Inpatient, that means that a physician has admitted you into the hospital, into that acute setting, because they believe you are going to require more than 2 midnights of care. And what we mean by 2 midnights is most Medicare regulation is going to go by midnight. And so if you come in at 1 a.m. in the morning and you stay all the way until, let's say, that 1 a.m. and you go, well, I've been here for 2 nights, let's say your case manager who is managing your discharge plan says, well, you've only been here 1 midnight, so you don't qualify for that. And you're like, well, I came in, I was here just last night, and you weren't there for the midnight. And Medicare goes by that 1201 is it 89? Mm-hmm. Yeah, 1201 89 setting. So that's important to know if you're like, well, I want to go to the skilled nursing facility, or what we call a lot of times nursing home, and do my short-term rehab. We haven't been there long enough in order to do that. And we'll talk more about what those regulations are. So observation means that, as it says, that a doctor must monitor you because you're not exactly stable, but they do not anticipate that you will be there for 2 midnights. This can become a problem when a patient presents to the ER. They do not anticipate a 2 midnight stay, but the patient declines. And this is based, your status will also be based on diagnosis. I have seen people in the hospital for 5 days under observation because they don't have a diagnosis, but the patient can't leave yet, but the patient is not able to access any of those resources that are required for an inpatient stay. So for example, and we'll get into this a little bit more, if you're at the hospital under observation for 5 days and you're a Medicare recipient, you cannot access your skilled nursing facility benefit because you are not inpatient. You have to be inpatient for 3 midnights under Medicare federal regulation in order to access your skilled nursing facility benefit, or what we call a nursing home.
Are you talking House,
I'm talking
Holy Cross Hospital, or are you talking Santa Fe, Los Alamos?
I'm talking, these are nationwide federal regulations.
This is not Taos.
None of this is just Taos. No, this
Okay,
applies.
I mean, this is huge.
Huh?
difference?
Not in regulation. They're all federally regulated. They have to do the same thing. And what I'm telling you right now, based on inpatient observation and acquiring benefits based on those statuses, those are all across the United States, the entire system. Anybody else have a question?
Did
Yeah,
you
I know
say 2 or 3 nights for the?
we're going to
when
get
you're
into
in
that a little bit
observation?
more based
Okay.
on, because we're going to go to some different facilities in the presentation. But for a skilled nursing facility, it's 3 midnights.
3 midnights.
I want you to remember 3 technically right now because we're still under COVID-19 pandemic regulations. It's only 2, but normally it's always 3, and they're going to stop that at some point. So it's best not to get the 2 midnights in your head at all. It's 3 midnights. So let's go through some of the different settings. We'll probably talk about, and this is what I was just talking about. So to access a length of stay, there's going to access facilities or different resources, your length of stay, that 3 midnight is going to be crucial. I just got ahead of myself. So the first one is skilled nursing facility. You're going to hear that as SNF, S-N-F. You're going to hear, I'm probably going to drop that if you want me to raise your hand and say, what did you say? Because I work in it all the time, and this is how we refer to it, as just SNF. But it means skilled nursing facility, and that is the exact same thing as a nursing home. So THC here was TLC, it's now Taos Healthcare here in Taos, is a skilled nursing facility. And of course they do long-term care and they do short-term care. They do rehab and everything like that. And this is the most common, not inpatient therapy. I shouldn't say that because a hospital is inpatient therapy. That's probably the most common. But it's the most common place that folks go at an inpatient location after leaving the hospital. Because remember, home health is not inpatient, it's in your home. And home health is the most common. People, of course, want to get better in their home. But a SNF is the most common. It requires that 3 midnight stay. Like I said, right now it's 2 due to pandemic regulation being relaxed. But that I imagine that's going to change in the next couple of months. So in order to go to a skilled nursing facility versus just going home and home health, you have to be at a certain level of acuity. So you must require around an hour of physical therapy every day, or have a nursing need such as wound care, intravenous antibiotics, you have a port or something like that, or you're incredibly diabetic, you've had new meds, very, let's say, very complicated medications that are causing a decline that you need to manage better. You'll go into a skilled nursing facility or a SNF to manage those jumps.
The third bullet point
Yeah.
says patients must be blah, blah, blah.
Must require, must
And
require.
all of that stuff. Who makes that decision and who tells the patient that they have made that decision?
Who tells the patient that a physician, so your physician you're attending in the hospital is going to be looking at this, and they're going to come into you and they're going to say, Jim, you know, you've had this, you fell and you broke your hip, and you're not, because they're going to be doing rehab and therapy with you in the hospital, and they're going to be measuring, you know, how far is he ambulating? How does he need meniscus, modicis, maxicis? If you're ambulating 250 feet with minimal assistance or no assistance after something like that, let's say they did surgery, you're going to come on to home health. But let's say you're max assist and you're only going like 10 feet before you're out of breath or you're in too much pain, they're going to say something like, Jim, we're going to, you know, we're going to refer you to a skilled nursing facility or an acute rehab, and we'll get into acute rehab. So your attending is going to make that decision, and then you'll have a case manager in the hospital that will carry that out and send the referral. They will have to give you choices. Where do you want us to send the referral? You know, do you want to go to THC? Do you want to go down to Santa Fe? Do you want to go to Albuquerque? Do you want to stay in Taos? You got one option. You know, so a physician makes that decision,
Okay.
and they have to certify all of that. There are Medicare forms where they have to sign off and attest. You know, and we get all that stuff on the back end.
Who are the case managers?
A case manager in a hospital is either an RN or a social worker.
And they work for, or at the hospital?
They do.
Yeah.
And they work for the hospital, and they do your assessment upon admission. You'll hear them say, discharge planning starts on admission, and they try to get everything done. It's their little jingle, you know. And they're going to try to get you out of there as quickly as possible and as efficiently as possible and to the right destination, because if they don't, Medicare comes down on them and says, well, why did this person stay here 2 days over? So if you've ever been in the hospital, and you're like, man, they're really like trying to get this figured out, and I'm just like uncomfortable, it's because clinicians are saying, you are good to go, and we got to get you out because Medicare is going to come back and they're going to either take money from us or they're going to fine us if our overall data does not, doesn't look the way that Medicare wants it to. Jim?
Okay, so we know who makes that decision, is the hospitalist, the doctor in the hospital who's taking care of you. Who pays for that stuff?
Well, for the skilled nursing facility or for your hospital
Any
stay?
of those paths?
So, yeah, so down here, I've got a note to talk to you guys about that. So Medicare, if you go, you do your 3 midnights, you go to a skilled nursing facility. Under Medicare, your first day, 20 days, 1 through 20, are covered at 100%, no cost to you. Day 21 through 100, if you do not have a co-insurance that they're in network with, so that's the other thing, you may have a co-insurance or a supplement or something like that, but that may not be a thing. It's a 20% copay to the patient. They can run you anywhere from $150 to $250 to $350 a day, depending on what you're being treated for in there. So somebody with like some kind of infectious disease, like C. diff, which if nobody knows what C. diff is, terrible bowel infection and virus, and it's not pretty at all. But because they're more critical, they have more supplies, they have to isolate those people, they get a much higher reimbursement for that. And so they are going, your copay is based on a percentage, so you're gonna have a higher copay if you're in that type of situation. You will also notice that skilled nursing facilities, I hope none of them are here, and I worked in it for years, so I can say it, they will start to try to push you out around that after about 2 weeks. Because if you don't have a co-insurance, they don't want to eat that. Because they know most people can't afford that. If you had to stay 30 days past your thing, we're talking $15,000 minimum for a copay. Most people can't do that. Most of the time they don't go send you to collections, they don't come after that. They just want you out of the building. They want to get you onto home health, and then they want to bring in the next person who's got all of their 100 days. So yeah, that's just the way that goes. Now, if you have a private insurance, if you are not a Medicare recipient, and you have a Blue Cross, Humana, Cigna, anything like that, you're going to have to call those folks to find out what the benefit is, because every plan's different. So my UHC, I've got like 60 days and 5 days are covered at 100%, you know what I mean? And Humana is going to be different. If you have a Humana replacement or a Blue Cross Blue Shield replacement Medicare plan, it's going to go through that. And so you'll need to call. It won't revert to Medicare in that situation. And all plans are different. They are not all created equal. So your home health benefit may be stellar with X insurance, and your SNF, your skilled nursing facility benefit, might be awful. So that you need to do your research on that. Yeah.
What about TRICARE?
I couldn't tell you. I don't know.
Because it usually pays for us everything that Medicare doesn't pay.
You'd have to call TRICARE specifically. We've taken TRICARE. I've taken TRICARE before. I believe all it requires is a prior authorization, which is very hard to get with TRICARE. Not because they are attempting to deny, but they're just a government agency. So I don't know, has anybody ever tried to call a government agency? It's hard to get through. So they don't move as quick as your Blue Crosses and your Humanas do, which are for-profit companies. They're a government entity, and they just move slower. So I've seen people come through with TRICARE and Medicare. In that case, a patient is allowed to choose when they have those two because they're both government. We always just go with Medicare because the patient will continue to decline at home in the home health situation. We're not going to be able to get out. We want to get out within 48 hours. Sometimes we don't hear back from TRICARE for 7 business days. And so we're already very concerned when that much time is going with a patient having been discharged home under home health, because we know that the chances of decline, the longer we're away from them or it takes us longer to get out, the more chances they are of declining in the home and returning to the hospital. And if you return to the hospital, you're going to have a longer recovery process if you do it, you know, all in the same kind of bunch. Nobody likes being in the hospital, and you know, studies do suggest people heal better in the home. So when you're just bouncing in and out of that cycle, it's not good for anybody. So you would have to call TRICARE and ask. It probably follows something very similar to Medicare, I would imagine. But I don't know that, Pam. So don't write anything down. So that's, in a nursing facility, you're going to have nurses around the clock. You're going to have PTs, OTs, speech therapists, anything that you need to kind of rehab you and get you better. And your medications are covered while you're there too, under that, because Medicare pays a per diem. So every day they allot a certain amount, and your medications are ordered through the skilled nursing facility, and those are all covered under that plan, that per diem rate. So the next one is acute rehab. So you can obviously see from acute, this is more of a hospital rehab. And these are often, they're very, very selective in who goes to these. You need to be able to perform up to 3 hours of physical therapy a day. So if you are at a point where you're exhausted walking so many feet, you know, ambulating so many feet, you're not going to be a candidate for acute rehab. You're doing it's very aggressive therapy for a very short amount of time, and Medicare and insurances want to see, because they pay more for this type of service, and you have like physicians on standby there, they're going to want that you're in and out, and that's why you're kind of going in there. The idea is that we put a little more up front, but we get more bang in the long run. And so Christus has an acute rehab, and so does, I think there's another one in Albuquerque that's not attached to a hospital system. But Christus is the closest one to us that you would be able to go to. And like I said, they're very, very picky about who goes to those, because you can't, there's nowhere, if you go to a SNF and you can't make it home, let's say somebody's at a point, and this happens, we see this a lot, where they go for rehab, but then they can't return home. They're not rehabable, we say. And so they end up staying at the nursing home as a long-term care resident. That's not an option in an acute rehab. They don't have a long-term care area. And so they can refer to one, of course, but they are very, they're graded very harshly by Medicare in order to keep their reimbursement up. And so they're very picky. I mean, it's incredible how picky they are. They want to see, you know, it happens, of course, where somebody needs hospice or they need to go to the SNF, to a skilled nursing facility, but not very often. Where it's much more common in a skilled nursing facility to admit and not rehab appropriately. And so there's just some different things here. You have to have special needs that have been determined. It's just much more rigorous, as you can see, than the other.
You have to be an athlete.
Yeah. I mean, it would be hard for anybody. You know, some people. I mean, if you worked me out for 3 hours a day, I'd probably fall over. But and you've got to have 2 or more therapy disciplines. So what you'll see a lot of time at acute rehab are neurological events, right? So somebody has a stroke, they have an aneurysm, they have left-sided weakness, so they're going to require physical therapy, and they're going to require like occupational therapy, because they're probably now going to have a deficit that they have to learn to live around. So you're going to see a lot of that, much more neurological event, as opposed to like hips and knees and falls and stuff like that. And you have to be there for at least 5 days. If they can get everything done within 2 days, you're going to a skilled nursing facility. So you gotta get out quick, but you see what I'm saying? You gotta get out quick, but you gotta stay at least 5 days. So they're very niche about who they do, and they've got it down to a science. I mean, they've got forms and formulas for everything. And you have to be able to participate in the plan of care too. If your stroke has rendered you unable to understand commands and different stuff like that, you're not going to be a candidate. You're going to have to go to a skilled nursing facility or come up with another plan. You can't, you have to be cognizant and have decision-making capacity in order to do that. So for Medicare, for acute rehab, you pay nothing for 1 through 60 if you're there. After the Part A deductible is met, you pay a per day charge between 61 and 90, and that's, I'm not sure what that is right now with Medicare, and I couldn't locate that whenever I was doing a little bit of research, but there's going to be a copay, probably similar to, I doubt it would be 20%, but don't, you know, who knows with Medicare. And then 91 through 150 are all, it's 100, or no, I'm sorry, you pay 100% of the cost after 150. Now, when we talk about a benefit period, it's after you have left and you have the hospital and you've had 60 consecutive days since you've been home without an event, and then your benefit period renews. So let's say Jane goes to the hospital on January 1st. She stays there for 5 days. On the 6th, she is then discharged to Christus St. Vincent Acute Rehab, and she stays there for 2 weeks. Let's say she leaves on January 20th. So she's going to need to have been home for 60 days, and then a new hospitalization has to occur. So if she went in and she, on day, let's say February 1st, went back to the hospital, let's say she had another fall, she went back to the hospital, she had some issues, so she stayed in the hospital for 3 more days, 3 midnights, and then she needed to go back to acute rehab. Her days do not start over. She just starts where she left off. But if she discharges from that acute rehab on January 20th, and then let's say in June, she goes back to the hospital, goes as another 3 midnight stay, she gets referred back to another acute rehab, her benefit period has started over. And that is the same thing with a skilled nursing facility too, the 60-day. You have to be home for 60 days and new hospitalization in order to restart your benefit. Because if you're in a skilled nursing facility and they send you home on day 21, and you're home for 5 days, you have another fall, you go back to the hospital, you stay for 3 more nights, and they start sending referrals to a skilled nursing facility again, you don't have all 100 days anymore. You're starting out behind. You've got 79 now, and that also makes you less desirable to skilled nursing facilities because you don't have your 100 days. So that's another thing to keep in mind too. I'm not sure about private insurances or TRICARE, Pam. You'd have to call those entities and ask what the benefits are for those types of people. Most people would never go to an acute rehab. It's so rare for somebody to go to acute rehab. But it is a place that you can travel to if your condition is that way. Okay, so the next place that you can go after a hospitalization is an LTAC, and that is just an abbreviation for a long-term acute care hospital, and sometimes you'll just see it as LTAC, long-term acute care. These are for folks who have very complicated medical problems that require a hospital-type setting, the acute setting, for a great length of time. We're not talking like years or anything like that. We're maybe talking a couple of months. So we've got a severely obese person, we've got a diabetic, and let's also say that he's antibiotic resistant and he can't move 5 feet without becoming completely out of breath and almost passing out. He's going to be a good candidate. And let's also say he's on a CPAP, right? Because he's obese, he's diabetic, he's got all these things going on. He's going to be a good candidate. He's going to take a lot longer to heal. And so these were created to take some of those out of the hospital because hospitals aren't supposed to be for a long time. They're supposed to be to stabilize and get you onto your next part in the care continuum. And so these are places, and like it says, usually for greater than 25 days. Hospitals never want to see anything like that. If you're there for more than like 3 or 4 days in a hospital, unless you're in the ICU and you're unconscious or something like that, and you'd stay in the ICU at that point, until if you weren't rehabable or you weren't getting better, then they would talk about moving you to a place where, let's say you were on ventilator support and something like that. They would want to find a facility that takes long-term ventilator support. When I worked in DC, there was a skilled nursing facility that they had a 100-bed unit of just airway, people that needed advanced airway interventions, and some people were not. They become wards of the states because they had nobody to speak for them, and the state, of course, never chooses to pull any kind of intervention. It doesn't have the right to do that, so there's no family to say stop this intervention and let the person pass on. So that is a very common thing in some larger cities. You'll see people that have been there for 10 years and they can make decisions on themselves or for themselves, and they have to be kept on that because they become a ward of the state, and the state can't make that decision to do anything like that. So those are going to go to like skilled nursing facilities, special skilled nursing facilities, and things like that. So they're very medically complex patients. And they can require physical therapy, but it usually means there's another clinical component. You're not going to go to an LTAC just to get your therapy. That's never going to happen. You're going to have a lot of clinical stuff going on in order to go to an LTAC. Yeah.
Where's the closest LTAC?
Albuquerque, and it is called. Give me a second.
That's okay, none of us will ever need.
There's one down there. I mean, you have to, these are people that have been sick most of their lives that end up going into LTACs and just very medically complex. I can't remember, I'll remember it whenever we all quit talking. So LTAC coverage for Medicare, remember if you're TRICARE or private insurance, you'll need to reach out. And I have no experience personally with working in an LTAC or working with insurance providers personally, so I couldn't tell you anything like that. But days 1 through 60, you have a $1,600 deductible. Days 61 through 90, you have a $400 co-insurance each day. Copay for LTAC, day 91 and beyond, $800 co-insurance for each lifetime reserve day after day 90 for each benefit period. So if you stay beyond 90 days, it's at $800 a day to the patient. At that time, most people end up having to get on Medicaid, and Medicaid covers the copay for something like that if they're in that type of situation. Okay, and then back to some I don't know, maybe it feels a little better to talk about home health. It doesn't sound as sad and sorry. There's hope. Wherever they post this, they can post my contact information. I tell everybody, it's a very complicated world. I don't have all the answers, but it's probably much easier for me to access the answers than for you all. So you're always welcome to give me a call if you're in the hospital and you're like, this is what they're saying. I just want to check it out with you. What are my benefits, kind of thing. Of course, I can't look at your records and stuff like that unless I were to come up and see you. But I'll try to help you navigate it as much as possible. Yeah.
I thought that you only qualified for Medicaid up until you were 64, and then you...
Not true.
I've been told that more than once.
Medicaid is different for each state. So not all Medicaid is the same. So, and I'll give you an example. In North Carolina, Medicaid is very based on income. So if you are, let's say I made below the poverty line in North Carolina, I could access Medicaid. They don't, there's not a barrier to that. But if I needed therapy, Medicaid doesn't cover it. Now in the state of New Mexico, Medicaid will cover therapy. So every Medicaid is different. Most of the time, Medicaid is a state-funded social service. Also in New Mexico, they're managed by private insurance companies. So Medicaid is managed by Blue Cross Blue Shield, by WellSky, Ambetter. I think that is incredibly unethical, and it's a huge problem to allow private corporations into the state-funded system, but that's another conversation. It depends on the state. And most people, most of the time it's income-based, and based on your need. What is your healthcare need? You know, so oftentimes somebody will present to the ER, go into the hospital, be really sick. Let's say it was a motor vehicle collision, and they begin to apply for Medicaid, like that short-term temporary Medicaid that you can get based on something like that. So there's all different ways, and there's different tiers of Medicaid. You know, the same Medicaid that pays for long-term care in the nursing home is not the same type of Medicaid that, let's say, a mother might have for her children that are under 18 and they meet those economic things. But always Medicaid is based on your economic or income level. Even if you have the clinical need, but you are very well resourced financially, you're not gonna, that's always the first thing. What do you make? How much money do you make? So no, it doesn't just start at 64. Now Medicare, of course, you
No,
can get.
they told me it ends. You can't get it after you're 60.
Oh, no.
Not true.
Tons of people have it. I thought you were asking, or you said the reverse, that you couldn't access it till you're 64. No, there's people 90 years old in the nursing home that are, Medicaid is paying for it. No, that's not.
Well, okay.
Yeah, no, that's not a thing. And actually, it's much more common to have it after 65, you know.
Yeah.
Once you've kind of went through, especially if you've had a medical event and you've had to go through your life savings, you know, and Medicaid even does, if we call it a spin down. If you're over-resourced, you know, they'll say you've got to spend down, and you can't just go like, you can't just take the money out of your bank account. Like, you have to show what you paid for. And if it was just
Can't give it to your friend.
No, you can't. You have to hold it for you.
That's not good.
You gotta, they're tracking all that stuff. So they'll do a spin down and then you'll qualify. So they'll say you qualify with a $10,000 spin down. So you better figure out, like, you know, do you need a new HVAC system in your house? That would qualify as something for a spin down, or a car repair, or a new vehicle because yours is old or something like that. But if they just see money disappear, you're kind of just shooting yourself in the foot. No, to your question. Anybody else?
Well, I think the biggest understanding, at least I have,
Uh-huh.
this happened to my mom. She had a congestive heart failure.
Mm-hmm.
And, you know, I always thought Medicare covers everything. Well, she had to go into long-term care. And had we not had a doctor
Yeah.
that would sign saying she
Uh-huh.
can't be at home alone.
Right.
And so she had the small amount of money we were
Uh-huh.
spend down.
Yeah.
It pays for your
And they got your
graveside or
Medicaid.
burial thing.
Yeah, that's a good point.
Those sorts of things.
Right.
And, but people misunderstand and think that Medicare covers long-term care, which it does not.
No.
And Medicaid, you do have to have a very minimal
Yeah,
amount of
it's
money. You get Social
ridiculous.
Security,
Yeah.
and they keep everything.
Right.
And you get like $100, it depends on the state,
Right.
I think. but-
And if you're what we call money poor, land rich, that will kick you out of being able to access Medicaid too. So that's something we run into here. A lot of people have land assets or home assets. Maybe nobody even lives in the home. It's just granddad's home that we don't want to get rid of, and you will get denied for Medicaid for that. So even if you're only drawing Social Security, so that's something we run into often here. And most states do a look back also. So for instance, in North Carolina, 5 years ago, my grandparents transferred all of their assets, which isn't much. It was like a house and some vehicles, right? They still live in the house, they still use all the vehicles, but they transferred everything over into my brother's name. And they did that because they're aging, and I had told them when I started working in this industry, get it out of your name. Because if you both have to go into a nursing home and you go to have Medicaid, Medicaid can take that home. They can take that asset. Now, if one person lives in it, they can't touch it. But if you both had to go in for some reason, and I've seen, or if one had passed away already and only one was living and then they went into the nursing home, Medicaid can collect those. And then Medicaid can look back 7 years and go back on that asset from 7 years ago. Not that they would give you Medicaid and then like take it from the person you sold it to or anything like that, but they would look back and say, well, you only transferred this asset 4 years ago. It still counts as your asset for Medicaid. So they've got 2 more years and we're all like, nothing happened. you know, because they wouldn't qualify. They wouldn't qualify for Medicaid right now because they would be over their asset limit. And yeah, Medicaid or Medicare does not cover everything with Medicare is short-term, everything. So it does not cover long-term care. When we start talking about that, if you need a nursing home, you're looking at cash. And long-term care insurance policies do not cover skilled nursing facilities. They will help reimburse for assisted living facilities. They'll help reimburse, some of them will help reimburse for care in the home, you know, like caregiver relief, but none of them pay for nursing home. Your typical room and board fee for a nursing home is anywhere from like $200 a day to $300, $400 a day, depending on how bougie of a place that you want to go to, you know. I think THC up here is about $210 a day, but don't quote me on that. And that's billed in, I think, 30-day cycles. So, I mean, where you're looking at, what's that, $6,000? And that's room and board. That's not like, okay, this medicine that we have to order for you is another, you see what I'm saying? It can add up. So I've seen people, you know, $10,000 a month is around about what you should expect to pay per month. How easy it would be for somebody to spend down in that situation too. I mean, if you've got 120 in the bank after a year or less, that's gone.
That's a good point too,
Yeah.
because she had some of that where she was in there
Yeah.
already.
Yeah.
So they were just taking the full amount and
Yes.
she didn't hardly have anything
Yeah.
left. And then
Yeah.
Social Security, they took that.
Yeah, and what they'll do sometimes is Medicaid will go, okay, like you'll private pay to go into the nursing home, and then you will tell them, okay, I've got X amount of dollars, and okay, we're gonna use this, and they'll have to be working with Medicaid, so that when you run out of money, your Medicaid will kick in. They're very, very efficient at that, because they do not want you going, they don't want you staying there at all if you don't have, if you're not paying some way, whether it's Medicaid. They're very efficient and very good at making sure that transition takes off.
But another thing to be careful of, if you just sign your home over to someone in your family, because I just checked on this with an accountant, what happens is you may have owned that home for, you know, decades. And if they inherit, then they're only having to pay taxes on from where you bought it. But if you put it in their name, then, and you're still alive, they're going to pay inheritance taxes on the cost of the present worth.
I wouldn't know any of that.
So I would
That's a
check
tax
with your accountant because
accounting situation, but yeah.
We had that issue.
Yeah. I'm sure plenty of people do. I'm not really sure. Home health, sorry, we didn't even talk about that. We've only got like 14 minutes.
Sorry.
So home health can be accessed. You do not have to go to the hospital. You can go to your primary care, and you can say, I'm declining, I can't leave the home, and I'm, you know, this leg's giving me problems, and they can order home health. The caveat for home health is that you have to be homebound for Medicare, and that means it takes a great, and it's very vague, like everything else with Medicare, it takes a great and taxing effort to leave the home. Our barometer is if you're driving yourself, you're not homebound. It doesn't matter if it took you 20 minutes to get to your car, you're not homebound. But if somebody has to take you somewhere, even if that means to the salon or church, you're still considered homebound. Now, if you're going to the casino every day, we're not going to stay, we are not homebound, right? But Medicare says that you should be able to get your hair as high as God and go talk to him also. So you can go to the salon and doctor's appointments. You can go to any of your doctor's appointments. But you got to be homebound. Medicare covers that at 100%, and it happens. You don't really, unless you start running into like where you're never going to come off home health, which hardly ever happens. We call them outliers, because they are outliers. I mean, there's been a couple people that have been on with us for years and it transitions to something else, but that is super rare. Medicare pays in episodic payments to the home health, which means that we put in your diagnosis, your care plan, your assessments, and Medicare kicks back and says, okay, we'll give you X amount of dollars. You see them as much as you want, just as long as you get them better. We don't care what you, like, we're not doing per visit payments anymore. We're saying we're giving you a chunk, it's that whole bundle payment thing, we're giving you a chunk, make it work, kind of thing. Now, private insurance and Medicaid pay per visit, and we often have to get what's called a prior authorization for those. I'm sure somebody's had to get a prescription prior authorization, and it's been very frustrating because it takes forever. Same thing for us, it takes forever and it's very frustrating. Blue Cross Blue Shield is really easy for us in the state of New Mexico. Humana, it's like working with the devil. It takes a lot of work and a lot of cussing to finally get something worked out with them. And so they'll basically say, you get 5 visits and let us know what's going on in 5 visits, and we'll tell you if we're giving you anything else.
And what would those 5 visits entail?
Such as?
Home health, I can have 5 visits. And so do they give me a bath? Do they give me medication?
No medication.
Do I have physical therapy? Or?
If you've got an injectable insulin, we will come out because there's so many variables with injectable insulin and monitoring your glucose levels that we do and can come out with an RN for that. We can send in a home health aide if nursing is in the home or if PT's in the home to help bathe you, but that's very rare. We would probably actually, if you needed help bathing, and I'm assuming if you need help bathing, we've got PT in there. Mm-hmm. If you're having a deficit around bathing, we're going to request occupational therapy, who then as part of their care plan can come into the home and teach you how to bathe yourself with this new decline or new deficit or something like that. And remember, home health is for a short period of time. We want to be in and out within 30 days. Of course, sometimes people are sick and we're in for 60 days. We are hardly ever in for more than 60 days. The ones we like to see are 2 weeks. We like to get you in and get you out because we know that that's just better for everybody. The longer it takes you to get where you're supposed to go, it's not as good for you in the long run. So you can access with home health an RN, a physical therapist, an occupational therapist, a speech therapist. An LPN might come out instead of an RN or something like that, and a home health aide may come out to help with something like that. But that home health aide may come out once a week for about an hour. They're not coming out to help do dishes. They're not staying for more than an hour. They are in and out, Ms. Doe, let's get it done, we gotta go, kind of thing. Because Medicare continues to cut reimbursement for home health. We just experienced another cut in 2023, and they've already told us to expect a 7% cut in 2024. And the home health industry is changing. It's really sad. So you can access all of those things depending on if a physician ordered it. Always a physician has to order the disciplines. We can't decide.
Is
Yes.
there a limit to the number of visits per week or per, like say you need an occupational?
Sometimes you can have somebody in there every day, and that's if you're really sick. So let's say you're diabetic, we just put you on injectable insulin. Well, let me back up. Let's say you've got a wound, a stage 3 wound on your buttocks, and you also had a fall, and so you've got physical therapy. So it's highly probable, and a social worker can come out if you need help getting your resources. It's highly probable that your nurse is going to come out probably 2 to 3 times a week to make sure the wound's healing, to do teaching and everything like that on the wound. And then it's very possible that your therapist is going to be out there 2 to 3 times a week, depending on the care plan. And it's all, so the PT, who's a doctor of physical therapy, and the RN are going to go out and say, okay, this is what's going on, and not at the same time. They don't really communicate much. This is what's going on with this person. I'm going to put you on 2 visits a week. And then we may want to see you 3 times a week for nursing, but then your insurance may say, no, you get 2 a week, and we're giving you 6. So let us know after week 3. And then we would submit for your physical therapy visits separate from your nursing visits. So then they may say, no, you only get 2 physical therapy visits a week, and we'll give you 1 OT visit a week. And you get 6 of those total. So holler at us after 2 weeks and tell us where they are. Because a physical therapy or any kind of therapist like that is much more expensive per visit than a nurse is per visit. So they really want to hold on to those and not approve as many of those. So it depends. With Medicare, again, because it's a bundle payment, they say we're giving you X amount of dollars for everything, figure it out. You know, so we have to go,
Oh, yeah.
okay, so this is where this person is, what do we suggest, and we kind of have to make it go from there, kind of thing. Because we know how much it costs us to go out per visit, and we kind of have to look at how much we expect to get reimbursed and go from there.
And these home health people come to Taos? I'm sorry, but I'm just
Well, now
like.
these are short-term clinicians, yeah, we've been here since 1975.
Okay, really?
Yeah.
Oh.
You're just lucky that you never had
Great
anything
to
to see
know.
us.
No transportation, no.
Yeah, well, we travel to people's homes, so, and again, you have to be that homebound, you have to be that homebound stuff. One of the other things that you can access is hospice. What I mentioned earlier about home care versus home health, and that they're very different. When we say, as industry people, home care, we're talking about private care aides that go to home and do homemaker services. So maybe somebody comes and sits with your loved one who has dementia. Maybe it's somebody that you need because you can't get around as much anymore, and they do your meal prep for you, they do your laundry for you. So that's very different. And Medicaid will cover homemaking services. The VA will cover, if you're a fully vetted or fully benefited veteran, you can get hours through the VA. We also do that at Mountain Home Health Care. They have to send us the request. We don't get to like reach out to them for it. So that's the difference between the two. We don't accept the Medicaid portion because they were cutting back payments so much. I have heard in this legislative session they're talking about moving back up because so many home health agencies stopped doing it. But they reimburse about $18 or $19 to the agency an hour, and then you've got somebody that's got insurance and benefits, and you're paying them 13 or 14. I mean, we were going in the hole, so we quit accepting the Medicaid portion. Plus, they just don't. It's bureaucratic, and it's really difficult to deal with them. So you may, if you have Medicaid, you can access those things. Otherwise, it's private pay. You need to have the financial resources. We start at $30 an hour for private pay in what we call our private duty or homemaker services. And that's industry standard. We actually raised it because we were not meeting comparable competition rates, that we had really priced ourselves down. And there's 2 or 3 other organizations in Taos that do that. One of them is AAA Home Care, and they're much more affordable if somebody's not able to meet that $30 an hour. Because it is quite expensive, especially if you're hiring somebody, even for 20 hours a week, it's a lot of money to ask for somebody. So that's that. The next thing is, and I already spoke about palliative, so if anybody has any questions about that, we can get in that here, but there's hospice. You can be referred by your primary care physician, your specialist, your oncologist. You can go into the hospital. It can come from a skilled nursing facility. Wherever you are and there's a physician, if they feel like you're hospice appropriate, then normally we'll get a referral to do a consult or something like that. The only thing that has to be done is 2 providers in the state of New Mexico. That can be an MD or an NP can also do that, because NPs are autonomous, PAs are not in the state of New Mexico. A physician's assistant is not autonomous. Right now they are because of the pandemic, but we hope that they make them autonomous after this.
What is an NP?
Nurse practitioner. So usually you'll see FNP, family nurse practitioner, or APRN, which is advanced practice registered nurse, which is also a nurse practitioner. But they function in a lot of the same ways in this state. If you go to Louisiana, they can hardly do anything there. So you may see an NP right now. Anybody in this room might see an NP and call them like doc, and they're not, they're not a doctor, but they function in that capacity. Now, once they get into a hospital, there's less stuff that they can do and stuff. But as far as primary care goes, NPs can do, they can see patients. They can have clinics without having MD oversight, is what I mean. They don't need, in some states, an MD has to kind of sign off on everything.
And oversight, does that mean there has to be a doctor on the premises with the PA?
No.
Or does it just mean a doctor can monitor the notes in the chart.
The doctor's accepting responsibility. There's an MD on record that accepts responsibility. So, you know, we work with El Centro Clinic, and there's not always an MD on one of their campuses, but there's always one in their network that kind of oversees. And they don't do a lot of oversight, really. I mean, when you really get down to it, which is why it begs the question of why they're even there. But it's, you know, I think the thinking sometimes is RNs have 4 years of RN training, like as a BSN, before they can go get that master's and apply as a nurse practitioner. So they have 7 years of experience. The minimum clinical experience is 3 years for a PA. So I could have a bachelor's in basket weaving and then go and get my PA in 3 years. Now there are other programs that are quite extensive and much longer, and you could have like, you could be an RN, you know, have a BSN and then go get your PA. It really wouldn't behoove you very much because you're more restricted. But it's just legislation in government that still does it like that. I think you'll probably see in the near future that New Mexico will make them autonomous. Because we're having a real crisis of healthcare practitioners in the state right now. I mean, we don't have enough doctors.
Is that because of the pandemic?
I think it certainly exacerbated it, but it was like that before the pandemic. It's a rural, poor state. There's not enough funding to get people out of their school debt. There's not enough sites where you can work to get your debt relieved from your school. And I think that's part of it. And then there's just not as much opportunity here. And then pay, I think, has always been the other issue. You can go to other undervalued areas or under-resourced areas and make a lot more. You know, you go work in LA, in certain neighborhoods in LA, and make a lot more money and get your debt forgiven or something. So I think that's why it kind of happens. We just happen to be, you know,
Poor.
yeah.
Well, we like the bottom in everything.
Well, the joke is, you know, you bring $2 million to Towson, you have like $1 million left over, right? That's what I heard whenever I got here. So that's just kind of what happens. And, you know, there aren't, when I moved here, and people were like, oh, what brought you here? And I was like, oh, work. And they were like, really? Like, you moved here for work to Towson? And even like in the state of New Mexico, most people my age in their 30s are moving out of the state for work and opportunity. You know, so that would count for everybody. I mean, we just have a workforce crisis in New Mexico, and I think we have for a long time, pre-pandemic. So you need 2 providers to state that they will not be surprised if in 6 months that you were to pass from your disease. You have to meet certain criteria with there's like several diagnoses: COPD, CHF, obviously cancer. A stroke can qualify you. There's different metrics that have to be met in all those diagnoses to qualify you. For example, dementia. Unspecified dementia is not a terminal diagnosis. Alzheimer's, which is a form of dementia, is a terminal diagnosis. And you have to meet certain specifications. Most of the time when somebody has dementia and it's just unspecified, maybe they didn't see a specialist or nobody really knows which type of it is, because there's Lewy bodies, there's frontal lobe dementia, different stuff like that. So most diagnoses are like just dementia, unspecified. So how we usually get them in hospice is because they have lost some motor function, cognitive function, they are not eating or don't want to eat as much, and we most of the time get them on like losing weight fairly rapidly. And that's really what happens, that's what most people die from with dementia anyway. So it's not uncommon for us to use that. We have to be very careful because Medicare doesn't like it very much, because there used to be a lot of fraud in hospice, and they would just put people on this, what we call protein calorie malnutrition, and they would just sign people up all day long on protein calorie nutrition, and so they got a lot stricter. So anytime that diagnosis is seen, it's a really good chance Medicare is going to pull that chart in the audit, because there was so much fraudulent activity in the hospice, and still is. There's a ton of fraudulent activity in the hospice industry. It's a very lucrative industry because Medicare pays a good deal for it because it keeps people out of the hospital. They know that most money on a person is spent in the last 6 months, so they create a hospice benefit to attempt to keep people, you know, increase quality. It's a wonderful benefit. I'm always like, I always say I pinch myself that Medicare still pays for it. We're all like waiting for them to say no more. But it does save them a lot of money if you can keep people out of the hospital, and Medicare, you know, wants to save money. So those are some of the other types of things with hospice that you can, and there's a myriad of other ways to get on hospice, but there's another place that you may travel through as you're kind of going on the care continuum. And the other thing that I want to talk about, just real quick, and I don't think I did, and that's why I left it. This was like a thought in the very, like before I came in today. Assisted living facilities, because they are an important part of all of this. If people that go into nursing homes have to require like 24/7 nurse attention, if you don't require that, they can't live at home, like the ALF assisted living facility is the in-between for that. Some states do have Medicaid programs for that, where they may just take your Social Security. So if you bring in like $1,700, they may say, okay, we'll call it even, just write us over the check every month. A lot of them don't do that because they're much nicer facilities, and that would be private pay. But again, some of those long-term care insurances that some of you might have purchased do, like they would write, basically you would pay the assisted living facility, and then you would send that invoice receipt to your insurance company, and then they would reimburse you, usually how that works. And if you need caregivers in the home, that's what happens too. You would pay an organization like me for the hours you use, and then you would submit to your long-term care insurance company, and then they would say, okay, we'll give you 70% of that and call it in. Gary.
Yeah, this is more 10 specific, and I guess it's more for me. A lot of times we'll get a call, we have elderly living with them, and we can't provide what they need. So I just want to know if I'm doing the right thing. I would refer them to home health. I would tell them that the doctor needs to write a script. There has to be a diagnosis. What they really need is a social worker to let them know, you know, resources available. So I guess a nurse would have to come in as a sort of the gatekeeper and.
Yeah, but let's say there is no, like, you know, their doctor's going to have to play social worker at that point. You can't, if the doctor writes me a nursing order and I go out there and there's no nursing need, I can't play social worker. And you can't send a social worker to help out by itself, which is good for everybody that was here. It's not what we call a standalone service. So it doesn't, you can't just have like a socio-economic or psychological, emotional issue to get home health. And we get those a lot, where there's just a lot happening, but there's not a PT need or there's not a nursing need. We'll get a referral for social work, and we can't go out because social work can't be the only thing in there. It can only come in as an added service. So that physician's going to have to play social worker to figure out.
Are the physicians here knowledgeable? Do they know the game?
Yeah. I mean, it would be great if we had a different program, like a county-wide case management system that people could get into, depending on how it was run and if it was efficient, because those things can also just be huge pains in the butt too. Most physicians it's getting to the physician, because most of the time to access any of these resources, you have to actually have what we call a face-to-face with the physician. And so if they can't make it, he's not willing to go to the house and do a house visit, then it's off to the ER they go. And then even that sometimes doesn't actually, it's too big of a solution for the problem. There's a gap in our system.
Could telehealth take care of face-to-face?
Who?
Telehealth?
Right now it does, because of the relaxed restrictions, and we actually anticipate that at least visual telehealth will stay. I'm assuming that it'll stay. Right now you can just have a phone call, and that counts as a face-to-face visit. It depends probably on who you're working for, because that's the way Mountain Home Health interprets the reg right now, because it says visual/audio, and we took the slash to mean or, not and. So that's what our rebuttal is going to be if they audit us and say, well, this was only like a phone call. Well, it just said slash, so you should have made it clearer. But so we're getting them that way, but we're also trying to discourage that, as we know we're coming down to some of that stuff ending, because we don't want that to be the go-to and then them not pay us when they find out that it ended, and then, you know what I mean? Because they love to take their money back at any opportunity. So there's a gap, Gary. If I were you, I would refer them to their, that you need to talk to your physician, that it's to, and especially if that physician referred them to tent, and
Yeah, that's probably where we get some referrals.
yeah, and it might be good for tent to call that physician and leave a voicemail and just say, we went and did our assessment, and I believe that they need, a higher level of care than what tent can offer right now. Because you've laid eyes on the patient, and that always lends a little clout. And I know your background too.
Sometimes it's a phone call, and I can tell.
Yeah. Well, and you were a PT for years, so I would throw that in there too,
Yeah.
Lend yourself some of that history and stuff like that.
What assisted living facilities do we have here?
Taos Retirement Village.
That's the only one.
It's the only one. There's about 4 in Santa Fe, and then once you get into Albuquerque. Albuquerque is a retirement city. I don't know if you guys know that, but people move from all over to retire there, and due to the weather. And there are tons of options in Albuquerque as far as all of this goes. I mean, it's just, if I were to go to Albuquerque, there's one called Advanced, it's a skilled nursing facility, nursing home. It's called Advanced Healthcare Rehab, I think, or Healthcare. It's a 5-star facility down there. It's Albuquerque's last 5-star facility. 5 stars is hard to get with Medicare, but it's super nice. And if I were to fall and something happened here, I would be like, send me to Albuquerque to that facility. Just because it looks like they feed you real good there, It looks real good. Yeah, so you've only got TRV, and TRV has independent living. So if you're not doing so good at home, you just kind of need more like wellness checks, because they do wellness checks on their residents. You can move over to their independent apartments, which are really nice, and then they can kind of transition you over to into ALF when it's time.
ALF, I'm sorry.
Assisted living.
Oh, sorry.
They've got 14 assisted living beds that they're licensed for in the state, and then they have the independent complex. And so they can transition people over. And I think if you're in their independent, you kind of get priority over like somebody from outside the village coming. I'm pretty sure, I don't see why you wouldn't. And Mountain Home Healthcare works with them all the time. They're excellent, like really top-notch, care a lot. And their director of nursing, Billy Odom, was just promoted to administrator. So she's running the show now, which is, I think, not that Brian before was bad. I liked him a lot, but Billy, I just think she's just the bee's knees. So yeah, yes.
I have one other kind, this is from personal experience, and it may change, changed in the last few years, but my mom was in California in a nursing home, and she was in Tennessee when I went with my company to Tennessee in a nursing home. And the term hospice has such a negative connotation to so many people, and I can tell you, it was a blessing, because whatever it was, she had congestive heart failure and dementia. But I was working, and she was like quite a distance away at the time in both places. But having that person coming in, because most of the nursing home, she was in a nursing home, they don't have the staff to keep an eye, and people are falling, or they need to be changed, or they've got a UTI, and having that hospice person come in was like having an extra pair of eyes, and that person would tell me what was going on. She was on Medicaid and tent care at the time, but she also had Medicare, thank you. But of course, Medicaid took care of her, took care of all of that stuff.
And then they could bill her hospice to her Medicare.
But if you need hospice, don't let that stop you because you think, and every 90 days, I think it was, they reassessed her. So that if she was still alive, they just said, okay, well, she's, and they might, I think
it's called a recert.
Like for a day or something.
Maybe they revoked her for a day.
And it was such a blessing to have that. To know that somebody was there telling, in California, not many speak English either, right? The techs, heavy lifting. So it was really, and also Tennessee, they're wonderful there. because they're very courteous to older people.
Yes.
Unlike California.
Yeah.
No offense.
Yeah, like,
I grew up in
the South likes our older folks a little bit more than the rest of the country. We're still tribal in that way, I think. Yeah, so nursing homes are very understaffed, and it's not that the people there don't, like, they want to do a lot more for their residents, they just can't. The reimbursement's not there. So I always tell people the squeaky wheel gets all the attention. If you're gonna go into a nursing home, your family needs to be there advocating, visiting frequently, because those are the people that they're gonna focus on, because they know that those are the people that are likely to lodge complaints.